invite Dr. Frances Collichio to come on up. She is our very beloved.
Do you want them with Bill?
She's our oncologist with the Melanoma program, one of our several oncologists here, and she's going to tell us about melanoma treatment and what the future holds.
Thank you, Paula.
Okay. Are you on? I think you're on. I don't know about that.
And I did not ride my bike here. Yay! I'm literally this wet from the bus stop to across the street. So when you guys go outside, it's going to be really cold because the front came in. So Dr. Ferris's presentation is actually a good segue to this, skin. I'm only going to talk about skin for this short presentation. I'm not going to do the mucosal or ocular because too much to cover. And I wanted to remind everybody about the mechanism of immune checkpoint inhibitors. So on the far left side of the screen is the immune checkpoint. This is fascinating, right? This is where something enters your body. It could be a cancer or a virus, and your body knows that it's foreign. And it creates this reaction which then goes to what Paula always says, the scene of the crime, where the virus is killed or the cancer is killed. But if this happened endlessly, we'd all have rheumatoid arthritis or Sjogren's or some autoimmune disease where we start attacking ourselves. So the brilliant scientists figured out that there's these, and this turns off. And the drugs that you guys often will take for your advanced melanomas are called immune checkpoint inhibitors, or offs to offs, which turns the immune system back on. One is the CTLA-4 inhibitor, which in this country is ipilimumab or Yervoy, and the other one is the PD-L1 inhibitor, which is nivolumab or Keytruda, pembrolizumab. So we're going to go stage by stage, and as you notice, I did not include stage 1 or MIS tumors because they're mostly cured in the dermatologist's office. And when you do lectures, you have to make sure you don't use anybody's real name or picture or anything, so you can get these off PowerPoint. So I always tell my students if they can pull the people off PowerPoint, these are people that have generously allowed their photograph to be used. So this is not a real case at all. But we'll pretend. So we have a 45-year-old teacher. She has no medical problems. She has a wide local excision for her cancer, a PET scan that's normal, and she's told she has stage 2C melanoma. Okay? So that's what she's told. And then she sees a medical oncologist, somebody like me or Dr. Muskos, and says, what do I do next? Well, it's actually very complicated in stage 2C, because it turns out that patients with 2C melanoma have a worse prognosis than patients with 3A. So we found out a few years ago that if these patients took a year of a PD-1 inhibitor, such as pembrolizumab, their chance of living longer without cancer goes up. And so we have long discussions with patients about this because we can't tell them they're going to be cured with these drugs. We can just say that you're going to live longer by taking this medicine. But we can also tell them that there could be a lot of side effects, which I know some of you have experienced with side effects from these medicines. So some of the patients will choose to do this, and some of the patients will choose to be followed. So in our fictitious case, she chooses to take the treatment for a year, and she's getting monitored. Okay? So let's move on. Now we have a stage 3A patient. Once again, I made him up. He's 32. He has a nodular melanoma on his back. He has no swollen lymph nodes. He has an otherwise normal exam. He sees a surgeon. We'll pretend it's Dr. Olilla. And he has a wide local excision, and his sentinel lymph nodes are removed. And there were 2 sentinel lymph nodes. One of them has a tiny bit of cancer in it, and he comes to see me. And he has stage 3A melanoma. So stage 3. Stage 3. So he has actually 2 choices. He's a 3B, not a 3A, 3B. And this is also a complicated discussion because he can take that PD-1 inhibitor, nivolumab or pembrolizumab, for a year. Or, since there's this genetic thing in his tumor, not inherited by his mom or dad, but in his cancer called a BRAF mutation, he could take a year of pills. So this is a long discussion with the patient to decide what he wants to do. And as of last summer, these treatments are equally effective in, once again, delaying the onset of cancer reoccurrence if it's going to reoccur. So the patient could be cured, or he's not cured, and if you take these drugs, you might improve your chances a little bit. So if he were to take the pills, we call those target treatments, and he could take dabrafenib and trametinib based on a study called COMBI-AD, or he could take encorafenib and binimetinib, which we often do because those medicines don't cause as much fever. Or he could take the pembrolizumab and nivolumab, or he could choose to be observed, which means CAT scans and exams. So let's see. So this patient chose to take the immunotherapy. Now let's take the same case, and now same exact patient, but this time, instead of the lymph node being something super secret and you don't feel it, he actually feels the lymph node, okay? So this is where it gets a little more complicated. He says, I feel this lump in my armpit, and on PET scan, it's a big 2-centimeter lymph node. So instead of removing that lymph node, guess what they do? They take a biopsy and they prove that it's got melanoma. And so this is where there's a difference between taking all the cancer out, which is thus far what we talked about today, versus applying a treatment to a person who has cancer still in their body. So the top is called adjuvant, means in addition to the surgery, and the bottom is neoadjuvant, means going before the surgery, okay? And there's 2 trials that your doctors might throw around with you in the clinic. One's called NADINA, and the other one's called SWOG 1801. And NADINA was the big splash, and last year's international meetings was one of the best 5 abstracts presented over probably about 30,000 abstracts for that meeting. And I'll show you why. I guess I didn't put a slide in that one. But basically, with NADINA, we were able to show that patients who had the treatment before they got the surgery, about 50% of patients had no cancer at the time of the surgery. So they avoid doing a whole additional year of immunotherapy. They could stop with just 6 weeks of treatment. And similar results we're hoping to see in the future by applying a few treatments of pembrolizumab or nivolumab and then doing surgery. But the standard of care for SWOG 1801 is that you keep going on with more immunotherapy. So very complicated if you have stage 3. Okay, so now, I hate using stage, and a lot of my patients will say, what stage am I, doctor? I think you need to have a little bit of that vocabulary, but sometimes when we use the word stage 4, that's it. It's Charlie Brown all the way. They can't hear you say anything else. So you guys have to understand that stage 4 in 2025 is not stage 4 as it was in 2002 when I started doing this. We actually can cure some patients with stage 4 disease. So our patient in this scenario is 60. She was diagnosed with stage 2B melanoma. She chose to be observed, and in one of her observation CAT scans, they see some nodules in her lungs. Everything's favorable for her. She has no brain tumors. She does have that mutation on her cancer called that BRAF mutation. So what's she going to do? So the standard of care for her is actually immune therapy. So if you have the option of using immune therapy for stage 4 patients, you do that over the pills, because with the pills, you really can't stop them. They're just something you have to take forever and forever. Whereas the immunotherapy, you can more short course and hopefully cure the patient. Okay, this is where we actually are spending a lot of time in our clinic, because a lot of our patients come to us from far around the state or states because they've already been through standard of care and their cancer has come back. So now what? So that's why we send Dr. Moskos to talk to the pathologist and do his high-level thinking all the time. That's all right. It's good music. That and the rain really woke me up. So this one, y'all, is after the PD-1 inhibitors, what is this patient going to do? So he comes to the doctor. He's had ipilimumab and nivolumab. He is found to have a lymph node in his neck, and CAT scans show that there's new disease in his liver too. So there's actually several standards of care for this patient. If the cancer has that BRAF mutation, he can take that medicine. Or they can retreat him with immune checkpoint inhibitor again, see if it works. It was a 6-month gap, so it certainly can. Or there's a combination of pembrolizumab with a really fancy pill called lenvatinib, or the tumor infiltrating lymphocyte therapy, which is called lifileucel. And to remind you all, because I think a lot of you were here last year, lifileucel is really kind of a technology where for really kind of our very robust, healthy patients who are in a situation where they're running out of great options, the tumor can be removed and then sent to the laboratory I think it's still in Pennsylvania, and these tumor infiltrating lymphocytes are grown. Then the patient is admitted to the hospital, undergoes chemotherapy to remove the healthy blood cells that are in the body and put back in the tumor infiltrating lymphocytes that were grown. And interleukin-2 is also administered to augment the immune system. So it's very fancy technology that works really well for some people. And then as we talked about with the Melanoma Research Foundation, heading this up is clinical trials. I would not be here today without clinical trials, because that's where all this stuff came from about 2008 till 2010. We were the ones, the melanoma groups, are the ones that created all of these drugs that are used in every cancer now. So let's push for more trials. This is the one I work with in clinic all the time. And every time I give a talk, people want to know about this virus. This is herpes virus. It causes cold sores. And this one has been genetically changed, so it can't make you sick. And when it goes into the cancer, it causes the cancer to break up and die. And then there's a message given to create a vaccine for the rest of the body. And so every week we're using this in clinic. We're administering it to tumors that we can see or feel. And then if we can't see or feel them, Dr. Burke or someone on her team will administer it by ultrasound guidance. And there's an example of a gentleman that we treated at the beginning of our trials who had a lot of melanoma on the side of his chest wall. He could not take immune therapy because he had myasthenia gravis. It was a contraindication to immunotherapy. And he went 10 years without any cancer after the treatment was given. And then here's another gentleman who I just saw a couple of weeks ago. His melanoma was in his neck, as you can see from that picture, and then also on his kidney. And so what's really interesting on that case is there was no other drugs at the time, and he got TVAC, and he had a nice result in his neck and on the tumor that was on his kidney. This year we have 2 people that have started this trial, Ignite-3, and this is a new virus that we call VO. It was made with the same construct as the herpes virus, but it's a little fancier. It travels better. It's probably a little bit safer. So we're pretty excited about this study. Patients get either doctor's choice, which for us will be a combination of nivolumab and relatlimab, or the virus. And when the virus is given, it's given with nivolumab. And then AB248 also opened this year. Fascinating study where instead of giving the patient interleukin-2, which has a lot of side effects, this is a product that makes an antibody that specifically causes the white blood cells that your cancer needs to fight the tumors to grow in the body. So that's why I have a smiley face on it, because it makes it much safer for the patient. So there's a lot. So, stay informed, call Paula often. She doesn't answer today, you know why. And, just be optimistic, because that always helps too. Any questions? No? Okay.